I am Sungkyu from Seoul National University Hospital, Korea. I'd like to talk about high-risk reoperative sternotomy anatomy. Repeat sternotomy can be challenging, with risk of injury to various cardiac and extracardiac structures. Perhaps more challenging, in particular for a young surgeon, is assessing the level of risk for injury on re-entry, preparing for how to handle injury to particular structures, and determining what measures should be in place prior to reduced sternotomy, depending on that calculated level of risk. The structures to be considered to do reduced sternotomy as follows: innominate vein, right atrium, right ventricle, ascending aorta or great arteries, coronary arteries. In addition, the following hemodynamic regions should also be concerned: aortic regurgitation with anticipated aortic injury during re-entry, intracardiac shunt with anticipated injury on re-entry, myocardial ischemia, and arrhythmias. Based on the preoperative CT scan, surgical strategies should be established, especially be carefully observing things such as aorta or conduit adherence or erosion into sternum, hypotensive dilated right ventricle abutting sternum, and dilated aneurysmal coronary button. I'd like to introduce some cases from now on. These are the cases where our fellows gave me feedback that they had a hard time doing reduced sternotomy in the last 2 years. First case is about 38 years male with DORV, VSD, PS. He had history of left modified BT shunt, RM BT shunt, and sending operation. He underwent quad reduced sternotomy. During reduced sternotomy, innominate vein was teared and femoral cannulation was performed to apply cardiopulmonary bypass. From the preoperative CT, we can find out the adhesion between innominate vein and sternum. In addition, it can be seen that aorta and switched atrium is attached to the sternum. Next case is about 44 years female with TGA, VSD, PS. She had history of left VT shunt, Russell operation, and aortic valve repair, RVPA conduit change. She underwent quad reduced sternotomy. Fortunately, there was no event during sternotomy. From the preoperative CT scan, we can find out aorta adherence into sternum and the calcified conduit cross forward and is attached to the sternum, indicating that it can be very dangerous when opening the sternum. Next case is about 26 years female with TOF who has previously undergone 3 times sternotomy before. This time, there was no event during sternotomy. However, coronary artery injury occurred when the previous RVPA conduit was removed. You can see that the calcified conduit and coronary artery is right close together. Next case is about 47 years female with TOF who has previously 3 times sternotomy before. CT before this quad reduced sternotomy showed retrosternal abnormal region with compressed ventricle. It was an organized hematoma and a very thick fibrous membrane was formed around it. The last case is about 29 years old female with DORV, PS, PAPVL, left isomerism. She had history of RV operation with patch closure, RVPA conduit into position, vegetation removal, and epicardial permanent pacemaker implantation. Even though it was the sixth sternotomy, the sternum was opened without a problem. However, there was a very severe adhesion, so the aorta was damaged, and ventricular fibrillation occurred several times in the process of separating the heart from the chest wall. From the CT, we can find out aorta adherence into sternum, pacing wire through the innominate vein, and a heart tightly attached to the chest wall. With sternotomy, I once say that well begun is half done. Thank you.